Bismillahirrahmanirrahim and Assalamu alaikum. My name is Dr. Maria Junaidi, and I am a stroke physician and the Vice President of MENA Stroke Organization. It is my pleasure to welcome all of you to the 64th edition of this MENA Stroke Organization Education Academy Cerebrovascular Grand Round. This is our fourth webinar of the year, and we have titled it Secondary Stroke Prevention at the Crossroads: Timing, Targets, and Treatment Choices. The session will highlight the latest advancements that have shaped the evolving landscape of stroke care. Just to bring our audience up to date, last year alone, our webinar series brought together a global audience of over 5,000 participants, reflecting the impact and value of our educational efforts. This achievement is, of course, supported by the distinguished faculty of about 40 to 45 speakers, including leading regional experts, as well as internationally recognized stroke physicians and academics. We are privileged to host this outstanding group of speakers who will guide a program that features the latest research. You get expert insights, and we have some very fruitful interactive discussions. Our shared goal, of course, is to enhance clinical practice, to advance standards of care in the region, and to improve patient outcomes at the end of the day. So a very warm welcome to all of our participants today. Thank you so much to all the wonderful speakers who agreed to share their knowledge with us. I would now like to invite my co-moderator for this session, Dr. Ahmuda Ahmad Ahmuda. Dr. Ahmuda is a senior consultant in internal and stroke medicine at University Hospital Sharjah. He is the founder and the clinical lead of stroke services at the University Hospital. He is also an adjunct clinical associate professor of medicine at the University of Sharjah, and he has an interest in stroke care, in medical education, and in healthcare quality improvements. I'm very grateful, Dr. Ahmuda, for your participation in this MENA Stroke Organization Grand Round, and I'll hand over the podium to you to introduce the webinar as a whole and then our first speaker. Over to you.
Assalamu alaikum and good evening. Thanks, Dr. Maria. Today, inshallah, we will explore secondary stroke prevention at crossroads, timing, targets, and treatment choices with Dr. Ashfaq Shuaib presenting ischemic stroke from ischemic stroke to anticoagulation, getting the timing right in atrial fibrillation. Dr. Muhammad Al-Makhlafi will talk about the future of carotid disease management, best medical therapy versus endarterectomy versus stenting in light of the new evidence. And Dr. Waqar Gaba will present refining speed in stroke hands-on perspectives on metallized 25 milligram. These are highly relevant topics, and I am sure you will find them both insightful and informative. The question and answer session will be after the lectures. Now it's my pleasure to introduce our first speaker, Dr. Ashfaq Shuaib. Dr. Ashfaq Shuaib, who he unfortunately can't be with us today, but he has recorded his lecture. The lecture will be from ischemic stroke to anticoagulation, getting the timing right in atrial fibrillation. Dr. Shuaib earned his MBBS from Khyber Medical College in 1980s and completed his postgraduate training in internal medicine and in neurology at the University of Calgary, followed by cerebrovascular research training in Canada and the US. He has held senior academic and leadership roles in the University of Saskatchewan and University of Alberta, where he currently leads the stroke program. His works focus on cerebral ischemia and stroke trials with over 450 publications and multiple international research collaboration. So next, inshallah, we will play the recorded lecture for Dr. Shuaib.
Assalamu alaikum. Let me begin by saying I'm so sorry that I'm recording this message. It is definitely much better if we could do this in person, so my apologies. I have the following task, and I've got to do this in the next 20 or minutes or less. So the title is Ischemic Stroke to Anticoagulation, Getting the Timing Right. I've added one little bit to this, which is starting anticoagulation in patients who've had a ICH, which would be towards the end of my presentation, because that also is very important to keep in mind. Let me start off by saying I have no conflicts for this presentation. I also want to make two quick preliminary observations before we dwell into the data. So first of all, there are multiple indications for anticoagulation in patients who've had a stroke, and I'll mostly focus on the top two, mostly on anticoagulation in patients who have atrial fibrillation. And most of you would agree that in addition to atrial fibrillation, we frequently see patients with left ventricular failure or individuals who've had valvular heart disease who are on anticoagulants at the time of their stroke. Unfortunately, many patients with atrial fibrillation are not discovered with the underlying condition until they have a stroke. So they may not have had anticoagulants before, but given the fact that they have atrial fibrillation, they would require starting their anticoagulants after their acute stroke. So this more or less falls in the category of patients with stroke and the decision of should we start early or late. The other group that I do not intend to talk about, but is an important group, is conditions that come up with their ischemic stroke and where you require anticoagulants. So, patients with multiple rapidly occurring transient ischemic attacks, more commonly now that we use CT angiograms or MR angiograms, you may see a thrombus in the artery, and then you've got to think whether you should anticoagulate them or not, as with patients that have arterial dissections. And patients who have venous thrombosis or DVT. So there are some small trials and lots of non-randomized observational data in these patients. And in general, the treatment is safe. But again, I'm not going to talk about these patients. So in our patients with atrial fibrillation, let me make two observations. First of all, most randomized trials, oh, I shouldn't say more, all randomized trials with DOACs compared to warfarin, one of the exclusion criterion was a history of previous stroke in the weeks to months preceding the randomization. So that data is kind of useless to us, whether we should anticoagulate early versus late. But fortunately, in the last, I would say last 3 years, since 2023, we've had 3, possibly 4 well done studies where the comparison between early versus late anticoagulation has been done in the settings of randomized trials with excellent SAPs or the statistical analysis plans so that we can make some fairly firm recommendations, and I'll focus on those for my presentation today. So what is the problem, right? I mean, why the fuss about early versus late? And here's the dilemma. I'm giving an example of one of our patients, comes in with an acute stroke, NIHSS of 1 on day 1, and then we decide to wait for a week, which was the standard practice in those days. But during this time, they have this patient has a large right MCA stroke and is severely disabled from it. So, you can make a point that had we started the anticoagulation early, perhaps we could have prevented this second stroke. It's an argument, right? We don't know. This is counterbalanced why we don't start early is example on the right side of my screen where you have a large stroke with kind of speckled mild hyperdensity suggestive of early hemorrhagic infarction. You start them early on anticoagulation, and this is what happens. You get a large bleed, and then you wonder, should I have started that anticoagulant? Would I have prevented this hematoma? So the question is, the equipoise, which I personally don't think exists anymore. And I'll try to show you that with evidence. So here's my presentation then. I'll talk about risk of recurrent stroke following atrial fibrillation, determine or at least figure out if there are any patients out there where you'd hesitate to start them on anticoagulation early. These patients in whom the risk of hemorrhagic transformation may be high. Then I'll dwell into the evidence that we just talked about and end up by showing some data on should we anticoagulate early or late following an ICH. I apologize, I'm close to a hospital, so I can't avoid those ambulances behind me. All right, so first of all, recurrent stroke following atrial fibrillation. It's interesting. I was looking for data on observational data on somebody who's had an acute stroke, and then you follow them over the next 30 to 90 days and figure out what's the risk of recurrent stroke. So that will come out from Elan and Optimist and the Catalyst data that I'll show you later on. But in the literature, if you look at these large studies and if you summarize the data for meta-analysis purposes, there are 23 studies that were identified that looked at risk of recurrent stroke in patients who are anticoagulated, which is hopefully the majority of your patients. And I'll offer you some numbers. So here's some work published last year in JAMA Neurology. I've put the reference for you at the top on the right side. And they put these patients into two categories. Patients who are anticoagulated with moderately high CHART score, or patients who definitely had a stroke before they were started on anticoagulation. So they kind of fall into two categories, and I'll give you the details in the next two slides. The first observation I want to share with you is that risk remains continuous. So if you look at the early risk in 90 days and then at 1 year and at 2 years, you can see that these patients who are anticoagulated continue to have recurrent strokes. And you can put them into somewhat of dichotomous into two groups. And here's the data on these two groups. On your left, you see the two groups. So no prior ischemic stroke, and the risk of recurrent stroke at 3 months, 1 year, and 2 years. So those who've had no previous stroke, they would have approximately less than 2%, 1.7% risk, 90 days, which is almost half, less than half of those who have had a previous stroke. So 90 days is 2.3%, increasing to almost 4% for those who've had no previous stroke, and 6.5% for those who've had a stroke, which increases to almost 6% with those who have no previous stroke. And those who have had a stroke is about 10%. So it's a large number. So our current research, and we are involved in two strategies. How to deal with these patients who are on anticoagulants, who are presumably compliant to their medications, and still leak out and have recurrent strokes. Our first strategy is to, believe it or not, randomize these patients to DOACs versus that other drug, the drug that the younger individuals who are listening to me today may not remember, warfarin. So there's a randomized trial comparing a DOAC apixaban to warfarin in those who've had a recent stroke to see if the warfarin group made fare better. So this trial has just started. Hopefully we'll get some answers there. Uh, to me, however, the more exciting groups of newer agents are the so-called factor 11A activated factor 11A monoclonal antibodies. So there's now direct head-to-head comparison trials. The one we are involved are the so-called Roxy Atlas, Roxy Incline, which are going to compare apixaban to the monoclonal antibodies. So very exciting stuff. These monoclonal antibodies are even more exciting than the small molecules, and many of you would have heard about the Oceanic trial that was published 2 days ago. We were part of that, and our bigger excitement, no, I shouldn't say that. The other exciting study is Librexia, where I'm part of the steering committee, so we will see. If I was to make a prediction, um, it will be the factor 11A antagonist, both the small molecules and the monoclonal antibodies that will be replacing DOACs in the next 5 years. So back to my presentation. So in the large clinical trials comparing warfarin to aspirin, they were looking at the risk of recurrent stroke. And when you combine all these trials, there were over 1,100 patients who had a recurrent stroke within the confines of being on the DOAC or warfarin. And you can see the number is pretty impressive. It is 7%, 7%, and carries a mortality of 12.5%. So very impressive. You've got to do something about these patients. I am going to refocus on my presentation. I only have 10 more minutes. So what are the group of patients that are at a high risk of hemorrhagic transformation? I've put this together for your attention. Most of you would agree that as patients get older, the risk of hemorrhagic transformation increases, especially if they have large widespread white matter disease or they have multiple cerebral microbleed, especially if they're more than 10. The larger the stroke, the higher the risk. The poorer their collaterals, the higher the risk. And if they've had thrombolytic therapy, they may have high risk. And patients that have amyloid angiopathy, and especially if they're being treated for infective endocarditis. These are the more or less focal cerebral factors. The systemic factors would include frailty, vitamin D antagonists like warfarin versus DOACs, uncontrolled sustained hypertension, presence of renal disease or hepatic disease, sustained hyperglycemia, and low platelets from any cause. I'm just putting in the low LDL for the sake of discussion. I don't personally believe that it increases the risk of systemic embolism. So now back to my data. I'm going to show you 3 pieces of evidence. This is the best study, Elan. I was sitting next to Jesse Dawson at a meeting when he first heard that his paper had been accepted in the New England Medical Journal. I was so excited about it. Very nice study. So basically, they looked at 2,000 patients, randomized half and half to those who were going to be treated with early anticoagulants, which was dichotomized into mild to moderate strokes, where the anticoagulation was going to start within 48 hours, or large strokes, where the anticoagulation was going to get started within less than 4 days, versus 7 days for the mild to moderate strokes and 14 days for those who had large stroke, so early versus late. And they showed that, interestingly, very interesting, I thought, that at 30 days and 90 days, the risk of recurrent stroke was not that high. So at 30 days, 1.4%. In the early initiated treatment, 2.5%. In the late initiated treatment, that increases to 1.9% in early versus 3% in late treatment. So, the numbers are, they're there, but not very impressive. So if you want to look at their details, symptomatic hemorrhage in both groups is very, very low, 0.2%. Recurrent strokes, as I mentioned, is less than 2% for those who are in the early initiated treatment, about 3% for those who are treated after 7 days minor stroke and 14 days large strokes. And I wanted to also show you the systemic embolism is fairly uncommon, but nonetheless, it does occur, and I've got the numbers there for you, 0.4% versus 1%. Let me come back to that in a second, because I'm going to talk about that a couple of slides down. So optimize is the second one. This came of work in practices, hospitals in the UK, very large study. Look at the numbers. They had 1,800 patients in the early treatment and 1,800 patients in the delayed treatment. Interestingly, very interestingly, you'd look at the primary endpoints, which was the same like Elan. The numbers are similar. So whether you start treatment early, less than 4 days, or late, on average 14 days, the risk of recurrent stroke, death, or ICH is 3.3% across both groups. Whether it's ischemic stroke or symptomatic hemorrhage, the numbers are similar. So here are the numbers. So 0.6% of ICH, 2.4% to 2.3% of ischemic stroke. And here's their, if you look at the figure, they kind of match at 90 days. There may be a separation. Understandably, you'll see more bleeds in those who get anticoagulated perhaps early, but over the 90 days, they seem to match. So if you include these data from Elan and Optimize and two other trials, smaller trials, timings, and START. Now the numbers of patients is fairly large, 5,400 patients, and your primary outcome occurs in 2.1% of patients who are treated early and 3% in those who are treated late. That less than 1% absolute difference now is quite significant because the number of patients is higher. And although they look the graphs look quite separated, but remember, it's only 1% difference. So here are the actual numbers, and the numbers are in favor of decreased stroke and better mortality if you treat them early versus late. And that is throughout the whole span, whether it's small strokes, large strokes, whether they've had reperfusion treatment or not, and whether they're young or old. So, final portion. Atrial fibrillation with ICH and restarting anticoagulation. So I'm going to share two slides with you, two studies with you. This is a study of about 15 countries in Europe. They randomized 300 patients equally to anticoagulants versus no anticoagulant in patients with ICH. And quite understandably, the risk of ischemic stroke was lower in those who are anticoagulants, and the risk of ICH was higher in those who are anticoagulants. So here's the numbers. You can see ischemic stroke numbers are significantly lower at the bottom in blue in those who are anticoagulated versus those who are not. And this is counterbalanced by an increased risk of bleeding in those who are early anticoagulated, or who are anticoagulated versus those who are not. The second small study is called Apache, where again, similar findings. If you anticoagulate them, this is a study for 100 patients where the numbers cross-match. So if you anticoagulate, lesser strokes. If you don't, or if you anticoagulate it, higher bleeds. This is the meta-analysis. It was published before Apache, and you can see that there is a significantly lower risk of ischemic stroke, but a significantly higher risk of bleeding in patients who are anticoagulated with a previous history of a bleed. And this is, like I said, my secondary. This wasn't asked of me, but I thought I will put it out there for you. My final slide before I conclude is that if you have a patient with a deep hemorrhage, you can possibly start them early with anticoagulation versus a low-bar bleed. In fact, I'm very careful for the low-bar bleed. The enriched data would say that if you suspect amyloid angiopathy, probably do not anticoagulate them. DOACs are safer than warfarin. You would consider anticoagulation if they've got mechanical valves, they've got high CHAT score, etc. And you would favor not doing them in the very elderly, or if they've had low platelets, they're alcohol abusers, etc. Final slide. I gotta keep it within 20 minutes. So risk of recurrent stroke is high in atrial fibrillation, particularly high in patients who've had a recent stroke. I favor in all patients starting their anticoagulation within the first 2 to 3 days, irrespective of the size of their stroke, except for those caveats I mentioned earlier in the very old elderly with frailty and where you suspect they may have underlying amyloid disease. One of the most difficult decisions for me is reinitiating anticoagulation in patients who have ICH. And given the enriched ICH data, we currently do not anticoagulate patients who have amyloid disease with cortical bleeds. I thank you for your attention. I'm going to conclude my presentation right now, and I'm very sorry that I'm not here to take your questions. All the best with the rest of the program today. Goodbye and Assalamu alaikum.
Okay. So we are very thankful to Dr. Ashfaq Shoaib. He has always been a great educationist, and he's always contributed to our MENASO webinars. Unfortunately, he could not be here with us due to his travel commitments, but inshallah, another time. We have another great talk lined up for you. I would like to welcome Dr. Muhammad Al-Makhlafi, who will present the future of carotid disease management, the best medical therapy versus endarterectomy versus stenting. And we know that there is some recent data in the last year and a half that we are all kind of we were all kind of excited about. So just briefly, Dr. Muhammad Al-Makhlafi is a neurologist. He's a clinician scientist at the Calgary Stroke Program. In addition to his training in stroke and interventional neuroradiology, he also holds a master's degree in clinical epidemiology. Throughout his career, Dr. Al-Makhlafi has been driven by a passion for finding innovative solutions to the challenges faced by patients with cerebrovascular disorders. He is also actively involved in teaching and mentoring the next generation of neurologists and stroke researchers. He has a number of publications in top-tier medical journals, and he has presented his work at conferences worldwide. We are again extremely grateful to him for all the contributions that he's had over the years to MENASO's educational agenda. And thank you again, Dr. Makhlafi, for being here tonight for another great talk. We are looking forward to it.
Thank you very much. Jazakumullah khair, Dr. Khan. And assalamu alaikum, everyone. And thank you again for having me in one of MENASO's educational seminars. It's a pleasure to be with all of you. So today I'm tasked with covering a large topic over a span of only 20 minutes. I may go a little faster in some parts. My slides are available, and hopefully a recording will be available to you to go back if something goes by quickly. But please feel free to post questions in the chat as well. I don't have any direct conflicts, but I'm a part of a steering committee of a couple of trials that deal with carotid occlusion in patients with acute stroke. So a little bit different topic than the topic we're talking about today. So what ambitious roadmap I put forth here, but I'll try to talk a little bit about carotid disease. I'll mention a little bit about the classification and some of the new the categories of carotid disease that may have not been on our radar for many years until recently, just to bring it to your attention, and then update you about the latest kind of evidence for best medical treatment, carotid endarterectomy, stenting, and most recently the treatment of asymptomatic carotid disease as part of CREST-2 trials. And then we'll talk about some kind of patient-centered precision medicine decision-making for carotid disease. So large artery disease in general account for about 25% of all stroke, and large carotid disease makes the majority of the subset. It also includes intracranial atherosclerosis and aortic arch, but I'd say about anywhere between 15 to 20% of all TIA and or stroke are caused by carotid stenosis. It's estimated that nearly 1 billion people worldwide have some form of carotid plaque. About 58 million have measurable stenosis, about 50% or more. For those with more than 50% stenosis who are more than 65 years old, it's about at least 5%, the studies have shown. There are some biases in the estimation here, but I think it suffices to say that it is not uncommon for people to have carotid stenosis. What is less common is being symptomatic, but the majority of patients are asymptomatic. And there is roughly about 25% risk of stroke among those who have a symptomatic severe carotid disease and present with TIO stroke, and therefore the risk of recurrence is high, and medical treatment plus some form of revascularization is paramount in preventing another event. And these are some of the images. I'll go over some of them during the presentation. What we see here, a carotid disease, is a coronal CT angiogram, and this is a reformatted 3D CT angiogram showing the area of stenosis. So the broad classification for carotid disease is whether it's atherosclerotic or non-atherosclerotic. The atherosclerotic mean that there is a plaque formation at the carotid bifurcation. Typically, the typical risk factors, relatively old age, but also high blood pressure, diabetes, hypertension, dyslipidemia, a number of lifestyle-related risk factors, including smoking and lack of physical exercise and so forth, all kind of converge to put patients at higher risk of plaque formation and then carotid stenosis. And the most common variant of atherosclerotic disease is the severe carotid stenosis, as seen here in this angiogram, showing an irregular plaque, ulcerated plaque with severe narrowing at the carotid bifurcation, but superior to that, there is the normal caliber of the carotid artery. And this will be what most of the evidence will be talking about is atherosclerotic, more than 50% stenosis. But I thought I'll throw a few classification and a few categories here as well, just kind of for your information. One of these categories is what we now describe as non-stenotic but symptomatic carotid disease. So those are patients who don't have severe narrowing. The narrowing is not more than 50%, but as you can see here, they have a carotid plaque at the bifurcation. Some of them are calcified, some of them even have ulceration and irregular plaque. And evidence have been accumulating saying that these are not an innocent bystanders. Until recently, whenever we see these ipsilateral to a TIA or a stroke, we'd always say, oh, the carotid is not severe. It's probably an incidental finding. However, to me, at least, this story is unfolding similar to a PFO, that we initially thought PFO is common. It's a typically a bystander. However, there is a subset of patients where these plaques are ipsilateral. There is no other etiology. Patient doesn't have any other explanation for stroke, forcing people to think that these are more likely etiological. So the story is still unfolding. I just want to bring it to your attention. I'm not asking for anything more than aggressive medical treatment at this time, but definitely there is ongoing or planned studies to look at revascularization for those patients, not to open the artery, but to stabilize the plaque. Moving on to carotid neuro-occlusion. So this is a subset of severe carotid stenosis, and the difference is the caliber of the internal carotid artery distal. So here, this is the common carotid artery. To your left is the highly enlarged external carotid artery, and you see at the bifurcation there is a severe narrowing of the carotid artery, and then the caliber of the internal carotid artery is collapsed. And I bring this subset of patients just because they behave differently compared to patients with severe carotid disease without neuro-occlusion. They require medical treatment. A small subset of them may require revascularization, but the evidence for endarterectomy or stenting in those patients is not as strong as patients with normal caliber of the carotid artery, but definitely a subset to look for and to understand their natural history and the changes that it might imply in their treatment. And then we have a carotid occlusion, and I'm talking here about chronic carotid occlusion, whether symptomatic or asymptomatic. And when I say symptomatic, meaning a TIA or a minor stroke, not in the setting of large vessel occlusion or a disabling stroke. So sometimes people are planned for CABG, for example, cardiac bypass, and they go for a carotid ultrasound for whatever reason, and they discover carotid occlusion. So those patients typically we treat with medical treatment, which may include in a subset of patient anticoagulation, but typically aggressive vascular risk factor reduction and antiplatelet therapy is all that is needed. Sometimes we repeat a carotid imaging in 8 weeks or so just to ensure that the carotid occlusion was not caused by a clot, that with our aggressive medical treatment, the clot revascularized and now the carotid has severe stenosis. This is a little bit different patient who continue to stay occluded, and there is no evidence until now for revascularization, although I'm aware that there are cohorts, especially from China and then East Asia, promoting revascularization of chronic occlusion. So there is still part of that story untold, but I think it's sufficient to say that the overwhelming majority of those patients, best medical treatment is all that is needed. So these are the atherosclerotic disease. So depending on the severity of the stenosis and the appearance of the internal carotid artery higher up. When we move to non-atherosclerotic, I picked just a couple of pathologies that I think will be of relevance. The first is carotid dissection. So those patients these conditions could be either traumatic or spontaneous. Thankfully, alhamdulillah, majority of them only present with neck pain. Some present with Horner syndrome, but it's not uncommon for them also to present with TIA or stroke, whether minor or major. When we do imaging with CT angiogram, we see this flame-shaped appearance, classical, which, as you can see to your right here, it indicates that there is a hematoma in the wall in these patients, and typically those patients are treated with antiplatelet therapy. There have been a couple of studies comparing antiplatelet to anticoagulation, which didn't show definitive benefit for anticoagulation, although there is a signal of benefit for anticoagulation. And obviously, the treatment modalities is different if those patients were presented with large vessel occlusion, with major stroke, or they develop hemodynamic symptoms, meaning whenever they stand up, they're unable to, they become weak on that ipsilateral side, and those patients would be referred for revascularization with stenting. There is no role for endarterectomy in those patients. Another interesting emerging concept is the carotid web. So this is thought to be an intimal variant of fibromuscular dysplasia. To your right here, there is an angiogram image showing a carotid web. So it's a small projection, small scar in the lumen of the carotid bifurcation. But if you see higher up in the yellow kind of arrows, there is beading of the carotid artery, classical with fibromuscular dysplasia. We see that in about 15% of carotid webs, but the majority would be an isolated isolated fibromuscular kind of shelf that you see here on the axial image as well. More and more, this has been linked to ipsilateral large vessel occlusion, especially in the younger population. There has been a number of cohort study promoting for either endarterectomy or stenting for those patients. It's still an area of active research. I'm only bringing it to your attention. It'll be very hard to see this on only Doppler ultrasound unless the operator was specifically looking for a carotid web. It's easier seen on the CT angiogram, but for a long time, we have called this as an incidental finding, and sometimes they may not get reported. So please look for carotid webs in younger patients with large vessel occlusion or younger patients with ipsilateral TI or stroke that is otherwise unexplained. Carotid webs is still, the story still has many chapters to come. And finally, radiation-induced carotid stenosis. So this is a little bit different on imaging, that the stenosis is higher than the bifurcation. Many of them can present with bilateral stenosis, and these patients are typically referred for stenting, especially if they are symptomatic, because endarterectomy in the setting of scarring in the neck will be problematic. I didn't want to spend too much time talking about the diagnosis. I think for this audience, majority of you have at least ordered one of these investigations. Ultrasound Doppler is still the mainstay of diagnosis in many centers. I encourage you to look for the velocities of the internal carotid artery. Anything less than 200 internal carotid artery peak systolic velocity is probably less than 50%. The CREST-2 trial is promoting high velocity, like something like 300 or 340, to say that this is an asymptomatic patient. This is a severe stenosis. So be careful and please look at the number. But with ultrasound, it's operator dependent. So please have a chat with your ultrasonographer and make sure they know what you're looking for in these patients and so forth. But CT angiogram, personally, I think, and worldwide, it's becoming the go-to modality because it shows us the lumen, it shows us the wall of the carotid, shows us the arch anatomy, so it helps us to select patient for revascularization and so forth. And I think the only time where it may not be accurate is if it's a heavily calcified carotid. In those patients, I still order ultrasound, but for 95% of the time, CT angiogram is all that is needed. MR angiography has been mostly a research tool just to look at the plaque morphology, look at intraplaque hemorrhage and so forth, lipid necrotic core and so forth. So, but still kind of hasn't caught up. I foresee it taking more role as we start to screen more asymptomatic patient for revascularization. But until now, I think out of all the modalities that are used, MRA is the least used modality for obvious reasons. And finally, I want not to discard TCD, transcranial Doppler. If you have someone with severe carotid disease or your kind of moderate disease, whether you're wondering is the plaque active or not, the TCD emboli detection is a very useful tool. If you started medical treatment and you want to see whether it's sufficient or not, I've seen a couple of people who had, for example, on aspirin, anticoagulation, or required increasing the intensity of medical treatment just because of persistent emboli on TCD. So don't discard TCD as a tool for investigating or stratifying patient risk with carotid disease. Moving on to the main bulk kind of treatment of severe carotid disease, whether symptomatic or asymptomatic. I think for this audience, kind of the three main modalities are best medical treatment, carotid endarterectomy, carotid stenting, and most of the time we need two of these modalities, best medical therapy for everyone, plus either endarterectomy or stenting. I have one slide about TCAR, which I'll talk about but that is kind of the new kid on the block. That is the new modality that is still kind of expanding. Until now, I think it's only done in the US. Calgary was the first center outside the US that did this procedure in our vascular surgeons colleagues, but it's still kind of something that is looking for an indication, I would say. So what is the best medical treatment for patient with carotid disease? So antiplatelet therapy is definitely the first line along with the other factors or the other modalities. So most of the time we'd use dual antiplatelet therapy for patient with symptomatic carotid disease. Even if it's less than 50%, I encourage you to consider dual antiplatelet, and until you have ruled out any other etiology, I think less than 50% carotid is a potential culprit, and starting dual antiplatelet therapy is evidence-based, at least for 3 weeks for any TIA or minor stroke, so you might as well start it until you finish the investigations. If people are not responding or have to clopidogrel or have been on clopidogrel when the event happened, then you can consider ticagrelor, but there is no evidence for direct benefit of ticagrelor over clopidogrel in patients with carotid disease. Lipid control is essential in those patients. The LDL less 1.8 millimoles or less than 70 milligram per deciliter. There is evidence to show that aggressive lowering of cholesterol is associated with reduction of the volume of the plaque. It's not huge reduction, but there is evidence supporting that. And in the acute phase, even if the LDL hasn't dropped yet, statin has an anti-inflammatory effect that helps with plaque stabilization. So anyone with large carotid disease or large artery disease presenting symptomatically, a high-dose statin is a first-line treatment. And then to help you with controlling the LDL, you can try fibrates or one of the PCX9 inhibitors that are still kind of new and haven't been rolled out and haven't been tested in patients with carotid or ICAD. They were used in very few patients in the CREST-2, so there is more evidence to come when it comes to PCSK9s. Blood pressure treatment is, I cannot overemphasize the importance of blood pressure therapy and blood pressure control. Patients' blood pressure reduction has been helpful in patients with carotid disease, with intracranial hemorrhage, like any symptomatic vascular disease. You won't be wrong by reducing the blood pressure. One of the questions is how aggressive should we reduce the blood pressure? And that's something that is still evolving. But I think if patients have very high blood pressure or for secondary prevention, lowering the blood pressure is essential for preventing future events. And then lifestyle modification, obvious kind of measures for everyone. I won't go. There are a number of studies that have shown the benefit of endarterectomy versus plus medical treatment over medical treatment alone in patients with symptomatic disease. There hasn't been a study that looked at medical treatment plus stenting versus medical treatment alone, but the field has moved on and stenting has been adopted to be a modality for carotid disease management. Ideally, the procedure or revascularization should be done in less than 2 weeks from the symptom onset, ideally from first few days if the patient has a TIA or a minor stroke and don't have a large stroke on imaging. Endarterectomy is done under general anesthetic, done by neurosurgeons or vascular surgeons. Very straightforward, the procedure that has been done now for over 70 years. Very low risk of stroke or complication generally, given the experience in this modality. But the main thing that studies have shown is a risk for none kind of cardiac event, mostly ECG and troponin driven, but there is also risk of cranial nerve palsy with those patients. So who should have CEA? Like endarterectomy is the first line treatment for patients with symptomatic more than 50% stenosis, unless they had recurrent stenosis after surgery or they had radiation or they cannot tolerate general anesthesia for any reason. At that point, they should be referred for stenting. This is the procedure that I do. So typically it involves this basket-like structure is a distal protection device that will help prevent large clot from migrating to the brain. Here before and after, the stent stays there, and typically it's a well-tolerated procedure done under conscious sedation. Anyone who's high risk for endarterectomy by default comes for stenting, but if the plaque is heavily calcified, I think that would be high risk for recurrent stenosis after stenting, or if the patient cannot take dual antiplatelet therapy, then that's no good because they need dual antiplatelet therapy for at least 3 months after stenting. Otherwise, the stent will thrombose. Studies that looked at the two modalities, endarterectomy versus stenting, showed the higher risk of minor stroke with stenting, high risk of MI in endarterectomy, but equivalent risk of major stroke and a little bit high risk of recurrent stenosis after stenting. TCAR is a combination of both, so it's done mostly by vascular surgeon. They do an incision at the neck, they puncture the artery directly under visualization, and then they clamp the artery, they reverse the flow. So there is a suction ongoing here in the carotid artery. That suction gets filtered and then infused back into the femoral vein. And then a stent is laid in a very similar way as a carotid stent is done. So it is kind of combination. You're doing an incision as in endarterectomy, but putting a stent as in carotid stenting. So it's reported in prospective single-arm cohort studies to have very low operative risk of stroke and so forth, but there hasn't been any randomized studies, and there is very few studies that are published. And as I said, it's still being done in a restricted centers and so forth. So it's still something to be kind of decided what actually its patient population, target patient population is. Finally, kind of looking at the asymptomatic patients, I've always put this slide showing that the risk of stroke with asymptomatic disease has decreased over the years due to the improvement in best medical treatment. I think the recent evidence have shown that perhaps revascularization may be needed. But before that, before CREST-2, all of the studies have shown that endarterectomy and stenting have equivocal kind of risk or similar risk. So if a patient is asymptomatic and they're young and they're keen to have surgery, especially if they had contralateral symptomatic disease, then you could consider either stenting or endarterectomy until CREST-2 was published a few months back. And this was a study, almost two parallel studies. One arm was a patient with carotid stenosis, asymptomatic, who were randomized to endarterectomy versus medical treatment, and another completely different study where patients were randomized to either stenting versus medical treatment. So almost two parallel studies. They selected the patient population carefully. They selected the centers who could undergo revascularization surgery carefully. So there is always that caveat of generalizability. But what CREST-2 has shown that in the stenting arm, stenting did much better, significantly better than medical treatment, while in the surgical arm, they were equivalent. There was no added benefit for surgery over medical treatment. And what that study concluded that for asymptomatic patient meeting CREST-2 criteria, medical stenting can add more benefit to medical treatment. And there was lots of excitement and people thinking of stenting everyone with asymptomatic severe carotid disease. And I just wanted to bring these points of note of caution to your attention that the CREST-2 was very selective patient population. The medical treatment was extremely aggressive compared to anything that in typical practice we could afford. The study has been ongoing for 9 years, so lots have changed in medical treatment, the GLP, PCX9, and so forth. So we don't know how that would improve medical treatment over revascularization, and we still don't have long-term evidence from CREST-2. So which patient you may consider with asymptomatic carotid? Those who have spontaneous microemboli on TCD or even have evidence of previous stroke on imaging, even if it was clinically silent. Large plaque, if there is impaired microvascular reserve, either with TCD or perfusion studies. If patients had, for example, mixed plaque, intraplaque hemorrhage, and so forth, or patient who had contralateral symptomatic disease who don't want to wait until this becomes symptomatic and rather get with the treatment. There are a number of classification. One of them on your right is more clinical, but the other on the left is an imaging to classify the risk of future stroke with asymptomatic disease. But I still think medical treatment in the overwhelming majority of patients is more than enough with the asymptomatic carotid disease, but there is role for revascularization in a subset of patients. I put this kind of just to say there are a number of treatment coming on, number of stent technology. There's dual layer stent that may help even with patient with non-symptomatic, non-significant, non-stenotic carotid disease. But best medical treatment is the first and foremost, the first line of treatment, surgery in those symptomatic more than 50 If they don't fit for surgery, they can go for stenting. Asymptomatic, be for the lookout and know that some of them may qualify for revascularization. Worth definitely a sit down with your interventional and surgical team to discuss which patient they would be keen on operating on and so forth. And then there's lots coming in terms of risk stratification and future medical treatment like GLP and PCX9 for treatment of carotid disease. Sorry for rushing the presentation. Hopefully that gave you some quick updates, and I'll be happy to answer any question during the panel discussion. Thank you very much.
Thank you very much, Dr. Al-Makhlafi, for this interesting talk. I believe it was and will continue very challenging in a nice way when you come to the carotid artery disease. So I think it's the diversity of the disease, it's the diversity of the patients and the comorbidities they have. Thank you very much. So now it's my pleasure to introduce Dr. Waqar Gaba to present on redefining speed in stroke hands-on perspective on metallized 25 milligram. So Dr. Gaba is a graduate from King Edward's Medical College, Lahore, with more than 20 years of experience. And he is board certified from UK in acute medicine, internal medicine, and stroke medicine. He has stroke fellowship from London. He is a fellow of Royal College of Physicians, Edinburgh, and fellow of American College of Physicians. Dr. Gaba is a former clinical lecturer for King's College London, and honorary senior lecturer for University of Leeds. Dr. Gaba is adjunct clinical assistant professor for UAE and Khalifa University. He has simulation expertise from Harvard Medical School. Dr. Gaba worked as a stroke consultant in UK, where he received Clinical Excellence Award before joining Sheikh Khalifa Medical City, Abu Dhabi. He is a stroke lead and program director for internal medicine residency at SKMC. Dr. Gaba is Royal College of Physicians Edinburgh Regional Advisor for UAE and Chair of Examiners for MRCP at Abu Dhabi. Dr. Gaba, the floor is yours.
Thank you so much for the kind introduction and detailed introduction. Can you hear me and can you see my first slide?
Yep. The slide, no, we can hear you, but not the slide. Not yet.
Okay, let me just go back again. Sorry. Can you see the slides now?
Yes.
Yeah. So thank you again. Thank you, BI. Thank you, everyone, for giving me this honor to join and present this very important topic in MENASO webinar series. I've been given this topic of redefining speed in stroke. I'll try to do the justice in next 20 minutes. So these are my disclosures, nothing major, and I'm using one AI for one image. So what we're going to do in next 20 minutes, we're going to do rapid recognition of stroke, which is very important. We're going to talk about what is the patient's journey through the healthcare system. We're going to see what are the reperfusion options we have, especially when we're going to talk about tenecteplase, and then ending up with some real cases. So I think probably the audience here is very much familiar with when it comes to stroke recognition, we talk about FAST and be fast. FAST was the initial one, started with Newcastle, UK, and then soon we realized that it was missing the posterior circulation symptoms, and that's how be fast was introduced. This is an image where an elderly patient after prayers in local mosque, in Sheikh Zayed Mosque in Abu Dhabi, getting a stroke, and the family recognizing the stroke symptoms and calling 999, which is most important. When we talk about FOSS, we know it's about face drooping, it's about arm weakness, it's about speech difficulty, and that's the time for you to pick up the phone, because time is brain and you lose 2 million neurons every minute. So imagine the patients have now reached the emergency department after ambulance have been called. And here I often say that you have to divide and rule. So nurses have a very important role to check the sugar immediately if it's not been done and do an ECG, while the physicians have a role to do a quick NHS score. And as we all know, it tells us that how severe the stroke is. Bearing in mind, even NHS score has a problem with the posterior circulation. So we're looking for any disabling stroke or non-disabling stroke. And as you could see, that the severity of stroke ranges from 0 to 42, with 0 having no stroke symptoms or signs, and 21 to 42 being the severe stroke. And the next thing is, which will help you to find out what can you offer your stroke patient, is last known well. LKW is often we call that, and that's very important, because that's gonna let you know that if the patient is within the window we're gonna talk about in a second, you're gonna activate the stroke code. Now, in most of our hospitals, including my hospital, once that code stroke has been activated, a lot of people get to know this, and everyone knows that now time is brain and need to not waste time, rather save time. So patients get some blood tests. As you remember, as you know, that we don't have to wait for those blood tests. Only in certain circumstances, you might wait for INR or creatinine, otherwise no, apart from blood glucose. In our hospital, this is a protocol that when code stroke is activated, you put a brain attack order set, that's what we call that, and you automatically get CT head and CT angio. Now you have two options, okay? If you are within the window of 4.5 hours, as we know, you have an option with the neurologist for IV thrombolysis. On the other hand, if you have an LVO, you have an option for mechanical thrombectomy up to 24 hours. For the sake of today, we're gonna have more focus on thrombolysis. Now, I've just gone through quickly through the journey of a stroke patient, which started with a stroke event in a mosque, recognizing stroke symptoms by the family, calling an emergency, and ambulance bringing the patient to the hospital where you got the imaging and you think whether the patient is within the window for thrombolysis or thrombectomy. And then there's disposition whether the patient afterwards goes home, rehabilitation, or unfortunately, as we do know, that some of them might die. So let's shift the gears and talk about what's very important here. I'm going to talk about tenecteplase versus alteplase. As we know, over the years, we have been dealing with alteplase as our option for IV thrombolysis. But as you could see, over last more than 15 years now, several trials have come to try to compare alteplase versus tenecteplase. Whether we talk about Extend TNK trial, whether we talked about then ACT trial from Canada, we talk about Trace from Chinese, another one TACE from Australia, another one from Original from China, and then a test again from Europe, from UK colleagues as well. One common thing among most of them was that there's a shift ordinate analysis telling you that you have more patients with less disability. So you have more patients with MRS of 0 and 1, as you could see, as those of you who know what modified ranking scale is, that means lesser disability, with the scale from 0 to no symptoms to 6 being death. So what's so special about alteplase versus tenecteplase? Tenecteplase is a genetic version of alteplase where the 3 T and K, as the name stands for, 3 proteins have been changed from T to N to Q, and K to AAA or quadruple A. So it gives you the longer half-life, it gives you more PA resistance, and it gives you lesser bleeding risk. Essentially, if you see this table, you have a half-life of 22 minutes, you have a dose of 0.25 mg per kg, with a maximum dose of 25 milligram. The most important thing, it's quick. You only have to give in 5 to 10 seconds. It's 15 times higher fibrin specificity with peer resistance of 80 times greater and with lesser risk of bleed. This is very interesting that you only have 5 doses in comparison to alteplase, where you can have, if you start from 40 kg, 0.9 mg per kg, all the way to 100 kg, you can see that how many doses you can have, up to maybe 60 kind of doses. And you have to prepare for the infusion. You have to give a bolus first and then wait for the infusion to be ready by the nurses. And it takes a lot of time. And that's where the key is. And that's where the tenecteplase has shown not only the benefit in terms of quicker giving the administration, but also benefit in terms of disability as well. So in our hospital, I came up with this PDF with the help of BI. Actually, we made this, that whatever I've just told you briefly, I put that here, the how to prepare metallize, monitoring post-thrombolysis, what's the most specific about what the table I just showed you. We then, the weight thing is there as well, the evidence is there, and the guidelines recommendation is there as well. So that helped us in implementing last year tenecteplase switch from alteplase. So now I will move on to the cases. So let's take the case 1. Case 1 is a 40 years old gentleman who came to us via the private car. His date of admission was 31st of January at 9:29 in the morning. He was BFAST positive. That's the first thing which we just established and understood. His LKW was 9 in the morning. So that means it was a witnessed symptoms, witnessed stroke within the window, well within the window. So he came quite quickly. So as I just said, our protocol says the stroke code BFAST positive, stroke code was activated, and the patient moves straight to CT. Now, in most of the hospitals, you will see that if the stroke code is activated, and if you have a BFAST positive patient, you might not spend much time. You might take them straight to the CT, which was the case in our patient. And it is advisable if you have in our hospital, the CT is in the ED department. So he had the CT, had a CT angio as per our protocol. And as you could see, that there was the sweetest thing which we want to see, that aspect is good and there's no bleed, there's no LVO on the CT. And from the radiologist point of view, there's no contraindication for thrombolysis. So the next thing is that obviously we brought the patient back to our critical area and tried to find out what his symptoms are, what's his NHS score, like as I said to you earlier. So we have established BFAST positive, we established LKW, we know he's within the window. We saw that his past medical history was only hypertension, but nothing else. The nurses, as I said to you earlier, that they will do the vitals and the sugar. The sugar was a bit on a higher side, 10 millimoles, though he was not known hypertensive. And his blood pressure was high as well. So now the decision is that with NHS of 8, what do we do? The blood pressure is high. As you know, the blood pressure, you have a contraindication here, and which is 185 over 110. So it's higher than that. So we decided to give him labetalol, 20 milligram given. And after labetalol of 20 milligram, his blood pressure started to come down. And actually, after repeated blood pressure measurements, it was consistently below 185 or 110. And based on his stroke and based on well within the window, we took a decision to thrombolyze him. Now, thrombolysis is easy now with tenecteplase, like as I said. So it's 22.5 based on his weight. It was given as a bolus within 5 to 10 seconds. And the patient was then transferred to a comprehensive stroke center. Once the patient transferred, we have a door in, door out time. You can see the door to needle time was a bit higher, 51 minutes, but still within the 60 minutes. And that's because of the blood pressure. We have to keep measuring and we have to keep giving labetalol and make sure that his blood pressure is fine. And on other hand, door in, door out time was, again, it was good. It should be less than 90 minutes. We later found out that MRI showed left thalamus-capsular acute lacunar infarct with bilateral centrum semiovale and periventricular multiple subacute lacunar infarcts, likely embolic. The comprehensive stroke center discharged the patient on statins and antiplatelets with MRS of 2. His TOS classification, as per TOS classification, it was small vessel disease. They think that based on the imaging and based on his presentation, he was more likely having a small vessel disease, which caused him to have this stroke. I'll now move on to my final and second case. So this is another interesting patient who is a 75 years old female, again brought in by the family in a private car. Date of admission 30th of August, this time at 9 in the evening. So she's interesting because LKW was 2015. All the family could tell us that the patient went upstairs to pray, and then they found her quite low conscious level upstairs. So we are taking the time from when she went upstairs to pray. She was actually BFAST negative. So when the ED saw her first, they found out that her past medical history was hypertension and dyslipidemia. She is normally mobile and independent. She's an elderly lady, has a bit of osteoarthritis as well, but there was no focal neurology at that time. And BFAST was negative, except the low GCS. So after a bit of time, as you could see, that it took us around 15, 20, maybe around 20 minutes to activate the stroke code, when someone from the ED physicians thought that this still could be a stroke because there was a suggestion of maybe right-sided weakness. So she moved to CT, and again, the CT was done. CT head and CT angio is part of our protocol when the stroke code has been activated. And that's the CT, again, showing you that there is a old chronic lacunar infarct in the right basal ganglia, but the LVO, there was no LVO, and the CT angiogram was normal. So that's the CT findings. So patients persistently had a bit of low GCS, 8 to 9, with now possible right-sided weakness, with repeat, with the vitals of normal blood glucose of 5.7 and NHS of 7. 7 mostly driven by the conscious level, the first things. Okay. Because the patient was still within the window and there was a high suspicion of stroke with a definite time of onset, TNK was given 22.5 milligram, again based on the weight, at 22:15. So you can see that the door to needle time is not really good, but still I have explained you the reasons for delay and the reasons for a bit of ambiguity, both in terms of the time of onset and both in terms of whether it was not BFAST positive to begin with. So the patient was transferred to the Comprehensive Stroke Center, and we found out from the Comprehensive Stroke Center, the MRI showed left thalamic infarct. And as we well know, the thalamic infarct can give you this loss of consciousness or low conscious levels or altered conscious level. And you can see the chronic right infarct as well. So acute infarct, left thalamus, diffusion restriction, and T2 hyperintensity. Our Comprehensive Stroke Center colleagues thought that this time this was cardioembolic from the description, and also found large PFO, though they thought that the PFO might not be causing the stroke in this old lady. So they put the loop recorder in for atrial fibrillation, looking for atrial fibrillation. So last thing what I know is that the patient was still not on anticoagulation, still sent home on antiplatelets with statin and the rest of the things after all the workup. So in summary, time is brain, seconds matter, not minutes. We need to recognize stroke with BFAST tool. We have to activate stroke code after confirming what's LKW. We need to do the quick NHS. Don't spend so much time on doing the NHS score. You should spend maximum 5 minutes in an NHS score and just find out that where is the pathology and how much is the NHS score. Do the quick CT. As I explained to you, sometimes you take them straight for CT. Think about whether they are within the window for thrombolysis or thrombectomy or both. And then this is very important, whether depending on what status of your stroke center is, whether you're stroke ready, primary, or does need thrombectomy and you don't have that facility, you need to send them to Comprehensive Stroke Center. That's it for me. I'm happy to take any questions. Thank you.
Okay, thank you so much, Dr. Gaba. That was very insightful, and I think quite a lot of our centers are now moving towards tenecteplase because of the many benefits it has, and especially in terms of the workflow. So we have about 15 minutes. We'll start with some question and answers, and I'd like all the panelists to pitch in. But Dr. Al-Makhlafi, I will probably start with you. I can see that you've already tried to answer the questions, but I think it would benefit the larger audience if we discuss them also. So the first question is, in patients with large artery atherosclerotic disease who are not for intervention, but also have atrial fibrillation, will you go with anticoagulation only or antiplatelet and anticoagulation?
Thank you. This is an excellent question in the common clinical scenario. So if it's an asymptomatic carotid stenosis, then I think anticoagulation plus other measures of dyslipidemia control and blood pressure and so forth would be sufficient. If this is a symptomatic carotid disease, or the patient had an event and we are not sure whether it's carotid or atrial fibrillation related, and the patient is not candidate for revascularization, then I think adding a single antiplatelet like aspirin to the anticoagulation for only a few weeks, for a short interval, could be considered just to stabilize the plaque in addition to the other measures. But definitely for the long term, anticoagulation alone is enough. I think we have more than enough evidence now to show that combination antiplatelet with anticoagulation in the long term has higher risk of hemorrhagic complication that outweighs any benefit of the combination. So,
okay, thank you.
Dr. Gaba, it's very nice talk, mashallah, as usual. So how did you find the transition from the old practice with alteplase to tenecteplase in your hospital? And, the door to needle time, door in, door out. How can you just share your experience with us, please?
Thank you, Dr. Ahmada. I think probably it was not that difficult, surprisingly. The more difficult, so the thing is that the evidence is a lot. There's too much, a lot of evidence to suggest that, yes, we could move from alteplase to tenecteplase. Obviously, practically, it's more quicker and easier as well. The only, I would say difficulty, but the only thing which I spend the most of time is in terms of educating the staff. Okay. And I dealt with it at different levels, like nursing staff, the emergency staff, the neurology colleagues, and internal medicine. So did lots of educational sessions to tell them that why we are doing it, how quickly we can do it. And before everyone was on board, we were not ready to start. The second thing is that it was important to make sure that all the pathways and systems are in place, that we don't have any confusion from shift from alteplase to tenecteplase. I was from the day one was of the view that it's exactly a switch from one to other. It's not like you have an option of both at the same time, because that will create confusion. So if ED knows that I can use both, then they will always ask me which one I should use and which one I shouldn't use. Okay. So when we decided that we're going to go for tenecteplase, okay, from that day one, we removed alteplase from our stroke kit. We have a stroke kit in different areas of the hospital. So we removed alteplase from there. We removed that from the pharmacy as well. So alteplase remained there for other indications, but not the acute stroke. Lastly, it was very important that obviously in the guidelines has been updated, and from pharmacy point of view as well. So I did few meetings with the pharmacy that they are on board as well, because because we needed to get the approval from pharmaceutical and therapeutics committee as well of the hospital to say that we can do it. And like as I showed you, that PDF file that helped a lot, because nowadays it's you can say that we are living in a world where everything is electronic. It's quicker to be used in WhatsApp or which is handy. Everyone has their mobile, which we can have a look. So that's how I made this PDF file, so that anybody can just have a look at it quickly if they want to do it. So for us, once we did this, after that, we have started seeing the changes. We have started seeing the changes in terms of DDO and in terms of DNT as well, which is very important. But I would say that you will see the real difference in another few months or so, because the data will accumulate and that will show you that how these timings have improved as well. Thank you.
That's great work.
And if I may add to Dr. Gaba, like certain centers, the cardiology were ahead of the stroke field, switching from TPA to tenecteplase. So if in certain centers the cardiologists have already made the switch, that may facilitate switching to tenecteplase for stroke after getting all approvals in hand. That's another point. Thank you.
Yes, what I found from our experience is the stakeholders is quite huge with the stroke service, and one thing which can give you the assurance that your education has reached everyone, if you can do a staff survey. We did one at University Hospital Sharjah, and we did find some holes here and there, which was very easy to fix, because sometimes you go to the assumption you have delivered the education, but when you ask people the specific questions, how about the dynamic, about the process, you might find some of them not up to speed what you thought they are at. So a staff survey will be a very good idea. Okay. I think this will bring us to the conclusion of our session. I would like to thank all of our speakers today for this wonderful talks. They were very, very useful. They were, every one of us needed all of this, this update on very important topics, from the anticoagulation and the atrial fibrillation and the timing. And I do agree with Dr. Shuaib. Ilani is I think will be most of people are using it when they say 1, 3, 6, maybe 12 to 14 days, depends on the infarction size. Also, then we have the talk about the carotid artery disease and the move to the metallized 25 milligram.
Okay. Thank you so much. Actually, we had several more questions, and we are running out of time.
Yeah.
Just maybe I'll take a couple of minutes to answer a couple of questions that were related to the atrial fibrillation part. So one of the questions was about the timing. So I think that is something that Dr. Ashfaq Shuaib did touch upon. So there have been 3 main trials. There's the timing trial, there's the big ones, there's the timing, then there's ELAN, and there's Optimus. And they've looked at starting anticoagulation early, like within 4 days, or later, 5 to 10 days, or up to 14 days also. And the conclusion is that it seems to be safe. Now, the question that comes to mind is, most of these, the 2 trials, timing and Optimus, kind of selected patients based not on the size of the stroke, but on the NIH stroke scale, and the severity was graded according to that. But if you look at ELAN is a beautiful trial. The methods paper is just, it's something that to really, look at. They divided it according to the size of the stroke, what it looks like when you eyeball on a CT, for example. And based on that, they have divided it up into a mild or a moderate or a severe stroke. And they found that there was really no difference whether you're starting early or you're starting late. Optimus has very recently, just 2-3 weeks ago, published another paper, a sub-study from their original study, where they have also looked at the volumes. So they did a sub-study just looking at the volumes of the strokes. And they found again that there is no big difference, even if you're starting early anticoagulation in large strokes, and Optimus had several, a good percentage, or almost 15-16% of the patients had severe strokes. They did not find any significant difference. The only concern is with one other question, which is what if somebody's got a hemorrhagic transformation? So thrombolysis did not have an effect modification on this, on the result, on the treatment effect. But so whether you're thrombolizing or you're doing thrombectomies, these patients, had no difference in terms of starting early anticoagulation. It was considered equivalent or non-inferior. But if somebody had a parenchymal hematoma, that was the only thing that kind of modified in the ELAN sub-study the outcomes. So the functional outcomes tended to be worse when patients had parenchymal hematomas. But particular hemorrhages, and especially if you're doing an MRI, you would tend to see a lot of patients with hemorrhagic transformations, which is something very commonly seen with cardioembolic strokes. So particular hemorrhages, this is the ECAS classification we're talking about, did not have much difference on the 3-month outcomes. It was only the parenchymal hematoma in which caution is advised, and you should be waiting for a longer period before starting DOACs. So I hope that answers the 2 questions that were related to the atrial fibrillation. We have many more. Unfortunately, time is short, and we have to close. We are again very, very thankful to all our panelists. I'm thankful to Dr. Ehmuda for co-moderating the session with me. Dr. Mekhlafi, it was a great talk. Dr. Gaba, we always learn so much from your presence, both of you. I'd just like to take a moment to invite all of you to the 11th MENA Stroke Congress, which is happening on the 8th and the 9th of October in Kuwait. This is a major event for the region and for our stroke organization. We will be bringing together leading experts and researchers and clinicians, not just from our region, but also a wider geography. And we are looking forward to having you. It's a fantastic opportunity to network, to exchange knowledge, and engage in insightful discussions that are going to shape the future of stroke management in the MENA region. So we look forward to welcoming you in Kuwait. Please mark your calendars and stay tuned for more details. Thank you once again for attending, and we look forward to seeing you in the next webinar.
Thank you very much.